Welcome back, everyone. I want to make it clear that I'm speaking as a faculty member today rather than as a Bccdc person, and basing my comments on 30 years in communicable disease, epidemiology, and infectious disease practice. But I also acknowledge that all of us have been learning according to our own disciplines, and it's going to be good to talk as a group of critical thinkers. I wanted to start with this, that I think we all want a safe return to in-person learning. And we've all been taking a look at the harms of 18 months of being out of class for really a generation of our students. At the same time, that group has had a huge drop in employment. Their work terms in practica blew up. We've had measurable changes in mental health, physical activity, nutrition, and socializing documented in the SPEAK survey and elsewhere, and even an increase in overdose in the university age group. 3 weeks ago, maybe 4, I would have stood with anyone who thought there was probably something wrong with our opening plan. We at the time had no mask requirement in crowded spaces, and that flew in the face of 18 months of learning about the population value of masks. We had no extra encouragement to immunize, and although we have pretty good apparent immunization rates in surveys, I could have left something of a cohort of vulnerable unimmunized students among our population. And we even had strange mandate letters from the Ministry of Advanced Education that you really weren't reflecting Bonnie Henry's office. But I think the folks at Advanced Education really just wanted to ensure that we got back to class. The problem, of course, is that transmission is continuing apace. We know it's 17 times the rate in unvaccinated people compared to vaccinated, and the unvaccinated are hospitalized at about 40 times the rate of unvaccinated. We also know that with Delta, we can get some transmission in immunized people, but with much lower efficiency. And the increased transmissibility of Delta means that the herd immunity threshold goalpost has moved upward. And so it's going to be harder to achieve that without additional measures. So something more needed to be done, but since then we've seen a return of the mask mandate. We've seen the provincial vaccine passed. We've seen the additional UBC declare or test approach come in. And so if you're wondering why there isn't a mandate, mandate really means that we tell someone that they have to be immunized, that has to go into them to be a student or a staff member at UBC. The only time we really tried that in modern times was with the vaccinate or mask strategy, which was thrown out in court. And the thing to remember is that in public health, we go for the least restrictive but effective means to get there. And we have to ask the question, have all other less intrusive measures been explored? And in essence, with the things that are coming online, I don't think there's any evidence that a full mandate would be required this time. We need to continue to monitor uptake. But on the contrary, we've had very brisk uptake with the nudges that we've seen. As for the question of online versus other learning, I don't want to speak for pedagogy and all your courses. And we've all benefited from blended learning over the last little while. But one thing my experience has taught me is that in-person teaching allows for more inspiration, more direct feedback, better study of student body language when students are struggling. It also allows for that full experience of post-secondary learning where you're on campus and you're enjoying full campus life. So, I mean, I could easily sit back at my place on Gambier and teach remotely, but I'd feel kind of soiled by my privilege in doing so if it did further harm to the young adults who pay us to teach. So if one of our students makes a personal choice not to be immunized, I am, of course, going to teach them. I think it's better if that person is online than the whole rest of the group. So I just summarize by saying, if we had to mandate, if it was necessary, we'd do it. But we have no evidence that other measures will not suffice in terms of getting us way up there with immunization and with other layers of control. And if we are entertaining a lot more teaching online, I'd encourage us to ask the question, whom is that serving, us or our students? And I'd really love to hear people's perspective on that. I'll stop. Thanks, Ashley.
Thanks, David. Okay, I am now going to ask Hugh to give a 3-minute preamble.
Okay, thanks, Aslan. Also, welcome back, everybody. Those of you that have already been on campus and felt the very positive energy, just about every place you go, you'll see that this is working well so far. We're having, I'm reaching out to faculty members that have already taught, and just the positive experience reported by everybody is unanimous. And that is, I guess all of us, as David was saying, were a little apprehensive. All of us had some degree of anxiety leading up to this, but so far all the evidence that we're collecting is that this is definitely the right move for all the reasons that David said, including, of course, overcoming the harms done over the last 18 months to our student population. Having said that, we also recognize within the education team here that there are challenges. There are immediate challenges around, for instance, the learners who are not yet on campus, for instance, international students. And so we expect that faculty and TAs and staff are going to need assistance in handling situations arising from those circumstances. We also recognize that there may be in-class issues. I have not heard of any so far, but around the masking policy, illness among students, illness amongst faculty. I was talking to Kate this morning, and she said that her students have already said, what happens to us when you get sick? So we'd like to hear what people's concerns are and see if we can address them now, or at least start thinking about them. And then finally, we recognize that, as David said, there are many benefits to teaching online that became apparent over the last year. It's been a challenge maybe to incorporate all of those in this term as we pivoted back to in-person teaching, but we want to assure everyone that we're keenly aware of those benefits, not least those around equity and accessibility to groups that were challenged in the sort of traditional learning method. And so in the long term, we want to make sure that we address those and we design programs and curricula that make the most of everything we learned in the last 18 months. I'll stop there. Thanks. First, and a huge thank you as well to all the staff and the faculty for your amazing work over the last 18 months, and all of it done in great collegiality and good humor. So thank you for that.
Thank you, Hugh. Thank you. And now, if I may, Michael, would you give us about a 3-minute preamble, please?
Absolutely. Awesome. Thanks very much. It's good to meet you electronically as well. I haven't seen you through email and so forth. Good to see you in person. And thank you very much, David, and you for the comments too. By way of a quick introduction, I'm a medical health officer with Vancouver Coastal Health. I'm one of the local medical health officers for the city of Vancouver, which means that as well as helping to prevent and control COVID-19 in settings like local long-term care homes, hospitals, and large workplaces, my work was working with UBC both on COVID management early on the pandemic, planning for the restart of academic activities over the past several months, and now still working on those activities as we move into the weeks to come. So I've had the chance to work with the various UBC committees involved in the planned restart quite closely. It's really good to talk to the Department of Peers and the in SPPH. I really appreciated David's opening remarks about the dynamic nature of both the pandemic and the interventions that we have. In every presentation that I've had the opportunity to give to UBC students, faculty, and staff, really tried to stress the fact that what we had laid out as a province for steps 3 and steps 4 of the reopening were always a potential pathway, steps that had dates that were the earliest possible dates for those changes, but not for a certain change. And really stress that week to week, day to day, these case rates, hospitalization, mortality, all of the other metrics that you'll be aware of being monitored very closely. And we had the opportunity to slow down, to scale back, to adjust our non-pharmaceutical interventions as we went along. So you saw that in July in the Okanagan with some of the changes to cases there. We've seen that in the north with regional specific interventions as well. And now we've seen that province-wide in terms of the return of an indoor mask mandate, the strengthening of the nudges in the form of the vaccination card to prompt people to get vaccinated in order to take part in so many parts of normal life at this point. And I think that those are totally appropriate to managing the fourth wave that we've seen and potential future waves with the increased transmissibility of the Delta variant. That transmission matrix isn't what it was during the first, second, and third waves when we had large proportions of the population unvaccinated, but there clearly still is the opportunity for a highly transmissible variant to move from people to people through communities, certainly much worse so in the relatively unvaccinated communities, which we've seen in some of those regions I mentioned, but also even in populations that might have relatively high rates. It's important to go higher still. We've never set really a target, but always just that the ceiling can be continuously raised in terms of vaccination coverage. And that I think has been well justified when we see more transmissibility of variants recently. So I think that the dynamic approach to managing things has been very important. There's never a view that we needed to go ahead with, for example, without masks or without any nudges towards vaccination or without rapid testing. No matter what, there's always been that opportunity to move. And I've really appreciated that as huge as the ship is, UBC being a city of around 80,000 people by day, depending on who's counting, the university has been, I think, tremendously nimble for a large organization and being able to move from week to week on some pretty challenging interventions directed by public health, balancing many different demands that are coming from reasonably from different constituents such as faculty and students. And I think that what we've seen is really good work to bring in the most recent mandates into the function of, again, essentially a medium-sized city with all of those different parts as the vaccine card and other interventions have arrived. So I didn't prepare a stack of slides. I imagine this is an audience that looks very closely at the data on a day-to-day basis. So I wanted to spend most of the time in conversation and looking forward to it.
Okay, thank you, Michael. So what I'm going to do is try to moderate the session as best as I can. And I would like you all to fire off your questions. The chat box is looking empty, but there is one question from Steve Morgan. And I will read the question and I will give a preliminary answer and then ask other people to maybe chime in on the panel. So Steve's question is, has SPPH asked students what they would prefer during these weeks of the data peak? I have had dozens of students reach out to express a preference for online at this time. So SPPH, in answer, SPPH hasn't done an explicit survey of all the incoming students, but we have surrogate evidence that the students are very keen to be back in school. And the evidence that is surrogate that we have is that the Masters in Public Health students were invited to a hybrid orientation, and that hybrid orientation was canceled because an overwhelming majority, 65 out of 66 students that are in-country students in the MPH wanted to be in person at the event. So the hybrid, so 65 out of 66 students wanted to be in person for orientation. So that's the surrogate evidence I have of the students' willingness to be back on campus. Now, if anybody else wants to address that question, please go ahead.
Maybe I'll just add. I can't add about any more about whether we've surveyed the students. I think Gaslam's, put it right, Steve. It's a great question. But what I would say, I think, as a public health faculty, is that we need to make sure that we are dealing with risk assessment and not just risk perception. And so I think in settings where we've got a very highly immunized student population, the returning of masks, yes, we, as Michael puts it, have to remain dynamic and keep our eye on what's going on. But the risk assessment right now is that that's not too crazy a situation. I think let's keep an eye on it. But the students are voting with their feet, as Aslam points out.
Anybody else?
Oh yeah. Sorry, it's Mika. I was just going to jump in to speak on behalf of the OEH program, although Karen and Hugh are here, but across our, what is essentially a 2-year program, about 24 to 25 students are on site and in the classroom, with the exception of some international students who want to be here physically on campus, but because of visa delays are not yet here. But we have an overwhelming majority of our cohort on site, on campus as their preference in the classroom.
Yeah, and I would just add to that. Yeah, just to add to that, I think as David said, I think understanding why these students are resisting returning is important, because some of them may benefit from some additional education. Some, I've got, for instance, 2 students in my class who have very long commutes, and they've been very honest that they would like to change their classroom hours to avoid a 4-hour commute, and I'm doing my best to accommodate them. So we really need to understand a little bit more about why students are choosing online education or online options, and do our best to reflect that need. But it doesn't necessarily have to happen this term. Some of these are long-term adjustments that we need to make.
And maybe I'll just add, it's Caitlin, that when we're thinking about what we communicate to students and what we survey, one of the things that we've been thinking about over the last couple of months is what can we do with the data that we get back? If students come back and say, we want to be 100% online, we want to be 100% in person, could we actually do that? And so far, we've been following what we've been getting from the Faculty of Medicine and from UBC in terms of what our classrooms look like. So we don't actually have a lot of choice in what we can or can't do with that data. So I think as we go forward with continuing to get information from students, like, we just have to keep asking ourselves, can we do something with this data? Otherwise, why are we asking? We're going to have a lot more pushback if we ask students their opinion and then we say, oh, too bad, we can't do anything.
It's Mika. I'll add one other comment, which is also that if in your classrooms there are students who need an accommodation, there are long-standing procedures at UBC to accommodate individuals in the classroom who are unable to attend in person for medical or for other family reasons. And so I'm happy to share those instructions with you. They're long established to accommodate. If you encounter a student who is challenged to be in the classroom now or for any other reason, not even pandemic related, I'm happy to share resources with you with regards to accommodation for students. That also applies for faculty and staff, but for students also a process for accommodation around disabilities as needed. Yeah.
And this is Trevor here now. And I have all the students who come to 502, and although we haven't actually met in person yet, I've had no direct contact from anyone apart from 2 who can't actually get there because they're still in China. There's been no, they know it's quite clear in the curriculum that there's an in-person session next week, and I've had no feedback to say, are you accommodating remote learners? So that's, it's anecdotal, but normally if people are not happy about coming on campus, I see all the students, there's 95 students registered on that course, very little feedback. So.
Kate, you had a class of 99. Did you in person initially?
In person on Wednesday. Yeah.
Most,
yeah. We have a few people who physically couldn't be there, and I surveyed them beforehand. A few comments about commute length as well, but it's primarily what I'm hearing from is students who haven't been able to physically get to the UK.
Thank you.
Thank you. So the next question in the chat box is from Joel Singer. It says, I'm not very concerned about personal risk of teaching in person, but I wonder about societal risk. So I'll take a first stab at maybe answering that question because I taught my course yesterday, the first course of my health economics course. And one of the first things we teach in health economics is about externalities. And externalities exist in economics when the personal benefit of something that accrues to an individual from an intervention, from a medication, or from vaccine, it's much smaller than the societal benefit of that same intervention. In the case of vaccines, there's a huge positive externality. Individuals, when they assess the value of a vaccine to them and the benefit it offers them, they only assess their personal benefit. And then really the societal benefit is much higher because they lowered the transmission rate by getting vaccinated. So there is a really good argument in requiring people to get vaccinated, not just based on their own personal benefit, but on the societal benefit. And so, Joel, your feeling about altruism and worrying about societal risk, if more people had that, that would be great. But even though we do not have that in the people who are unvaccinated, the requirement for vaccine passports, what it does is attenuates the benefits that unvaccinated people enjoy, because suddenly they can't go to social gatherings and restaurants and things like that. So coupled with the disclosure requirement and the vaccine passport, I think we are going to a very safe area with the background immunization rates we have. And so that's my quick economist answer, but I'll open it up to others to join in. If not, I will go to the next question, and it's from Elizabeth Samuels. And
Aslam, it's Mika. Oh, sorry, am I muted?
Mika.
No, I was just going to say, if this is helpful, Hugh shared with me this morning a report on the mental health of youth in British Columbia from Bccdc. Yeah, and so that may be a helpful report for individuals. I can share it, make it available in terms of the societal impact and also the impact of COVID, the pandemic, on the mental health of youth in BC, but also thereby the benefits of returning to campus, to education, to the workplace, to social interactions as well. So if people want more reading on societal impact, I'm happy to share that Bccdc report, make that available. Thanks.
Okay, thank you. Instead of me reading out the questions, perhaps I would direct the panelists to read the next question in the chat box from Elizabeth Samuels. She's asking about the availability of COVID-19 testing.
We can't see the,
chat
on this end.
Oh, you can't see the chat? Okay, so sorry. So are there any updates in terms of plans to provide COVID-19 testing for symptomatic students, staff, and faculty who live on campus and do not have access to a vehicle? My understanding is that there's only rapid testing for asymptomatic community members currently available. Happy to be corrected if this has changed or is incorrect. And while you pondered that question, the panel, may I ask whoever is the controller of the chat to make it available to everybody?
Go ahead, Michael.
I can speak a little bit about the testing sites. Right now, where the testing sites are, it's been determined over the course of the pandemic. There's been some that have been expanded, closed, and open, depending on community needs, depending on local case rates and the incidence at the neighborhood level. So there's not a plan currently to expand testing sites into UBC campus. We have noted, and certainly in our public health program, we're always looking at equitable access, putting geographic barriers. Definitely, I've discussed as the MHO trying to work with UBC on these issues, discussed with the operations directors managing testing sites, the potential needs of the student population who may not have the mobility to get off of campus. So we'll monitor those case rates. And of course, if there's an increase, there's always the possibility we've been able to stand up new testing sites at new locations. But for the time being, that this has not been that justification to have a specific testing site. At UBC, we do have two different rapid testing programs for asymptomatic screening, which we can speak a little bit more to. And there's also people who have access testing when they aren't able to get to the ACH testing site. So we've gone to urgent care and had a swab taken there. But overall, we generally found, including during a recent cluster of cases, that people were able to get PCR testing when exposed and experiencing symptoms.
Thank you. Michael, I don't know if other people are, your sound comes across a little bit muffled. So maybe if you could speak a bit more directly into your microphone, that would be good.
I have a message in my chat that I'm a bit loud too, so maybe I'll try to.
No.
Less
I think it's not the sound level, it's just a bit muffled, I found.
Okay, I'll try to reorient myself here. Thank you.
Okay. So thank you for that. And I don't know if Sabrina Wong is online, but Sabrina told me she has some limited spots. She has some spots available for testing on campus. Is Sabrina online?
I don't think so this morning, Hugh, but Aslam, but Hugh has some comments he can add.
I was just
Okay.
at the last meeting where the provost or the vice provost was talking about testing. They were talking about clinics on campus, but maybe they haven't actually been set up yet. But they were talking about the possibility of going to student health services and also the acute care when the student health services was closed. So we can follow up on that with the provost's office and make sure that that's communicated to everybody.
Yeah, I'm happy to add a little bit as I sit on the post-secondary institution committee that's busy debating how to support post-secondary institutions to do this. So Trevor Corneal, Director of the Public Health and Preventive Medicine program, and Medical Health Officer with Northern Health. First of all, it's important for people to understand that we only offer testing to symptomatic people through our health authority labs. So specifically the testing centers that everyone goes to. And those centers provide PCR-based testing, so molecular testing. And they will continue to function in that way, as Michael has indicated, with availability online should you have symptoms that you can go and get a test. There are some pilots within the region of point of care testing for that purpose, but it hasn't proven to be a particularly useful exercise for symptomatic people. For asymptomatic persons who are unvaccinated, it is very much a decision of the institution or the operator whether or not they want to implement that additional safety measure. UBC certainly has planned on doing that. What's being determined right now is what that will look like, what is the most feasible for, we estimate to be approximately 2,000 unvaccinated persons on campus. And we should be hearing more about that either today or early next week. The testing will be available on campus. I have not heard of it being available off campus at this point. But if you do test positive on a point of care test, you would be asked to self-isolate and go and get a PCR test at one of the B-stage testing sites, and then wait before you return back to campus.
Thanks, Trevor. Instead of trying to get to as many questions as possible, Chris McLeod has a question. Can you speak to the process to support available if the instructor is unable to come in due to illness or symptoms? I think the quick answer to you, Chris, is that the same support that's available to everybody if they're unable to teach their course or something like that. And I'll ask Hugh or Mika to supplement me. I think your question is directed to the fact that suddenly you either find somebody else to deliver your lecture or arrange for an online presentation, because obviously if you're ill and you have symptoms, you should not come in. Anybody want to add to that?
I just want to emphasize what Aslam is saying, that of the layers of protection, that staying home if you're ill is really important. And so we want to make sure that's front and center with our communication to our students as well. Okay, so the next question I have
is from Austin. And what is the policy? If I cut people off because I don't know if you want to speak and I want to keep this thing going, maybe you could answer it on the chat as well. Somebody wants to speak, I see.
Oh, was that me? Oh, I was just following up to that first question, which is if you are ill as an instructor and you're staying home, if you're at least able to signal to Caitlin or Hugh as the education director or Caitlin as the education manager, we can put all of our resources behind either finding a substitute teacher or rescheduling your class for when you are feeling better. All those things can be put into place. So if you can figure out a way to signal to us that you're ill, we will deploy the whole education team and our colleagues to support the continuation of your course. Thanks.
And it sounds like, Chris, in your case, Mika will step in and teach your course.
Yeah, I will teach Chris's classes. Yeah.
Well,
okay, so let's go to Austin. Let's go to Austin.
Wait, Trevor.
Hi, sorry, this is Trevor Dummer this time. Well, I think you're just about to ask questions about masks. My question was, what's the policy on, obviously we're all wearing masks in the lecture theatres, but does the instructor have to wear the mask while they're instructing? Because I've seen conflicting evidence that you keep it on and talk, and then there's some talk of plexiglass and you can take them off. So what is the actual, what we're supposed to do?
So I can tell you what the Bccdc public health recommendation is, and all of the post-secondary institutions were a part of developing this, along with the advanced ed, the Ministry of Advanced Ed, and the medical health officers. So this is the public health recommendation, is that face coverings be worn by anyone age 12 and older, including students, faculty, staff, or visitors, in all indoor public spaces. This includes lecture theaters, classrooms, teaching laboratories, and other indoor instructional settings. Instructors and other presenters do not need to wear a mask when behind a barrier or 2 meters away from students while teaching in indoor public spaces. And masks are not required for workspaces such as office areas, research labs, or shared offices, or for meetings and seminars in small meeting rooms. These are the recommendations, which are different than what UBC's policy is. I actually haven't seen what UBC's policy is yet and where it's landing. So I would leave it to you to articulate, or you as them to articulate, what we want to do while this settles.
And that was my confusion, because I think I felt I'd seen 2 UBC policies, some that Hugh had sent, and then there was something else from one of the other provost offices that said actually you could take them off.
It is tricky because the UBC links to this guideline. So I think there is confusion, and the provost office is going to have to clarify it. But the question is what we do as instructors in the interim until that settles on this one.
So, I mean, my understanding is, as you say, the policy is that we should be following is the public health guidelines, and they make sense to me. The one caveat that has been raised a number of times is that we should probably be modeling good behavior, and so that and if you can keep your mask on as an instructor, you should. And I have found, thanks to Karen Bartlett, that the type of mask you wear actually makes a huge difference. So both Karen and I are modeling masks that are made for choirs, and it turns out that they're actually very easy to communicate through, and we'd be happy to share these little tips with anyone else. So there are ways we can accommodate ourselves, but that is, to my understanding, is that if you're greater than 6 feet away from the front row of students, you can certainly take your mask off. And given that you're the one that's, and especially if it aids with communication, if you think there's a loss of clarity.
So this is Karen. I'm going to chime in. You can also hear my voice through the mask. I'm also looking into getting them branded, but anyway, that's not what I'm going to talk about. I think that it's important to know is that the other layer, the elephant in the room that we haven't talked about, is that the big classrooms, the big lecture theaters on campus have been upgraded over the summer, but offices and other small seminar rooms have not.
For HVAC.
For HVAC. And so we can't, I'm on that committee, and I cannot tell anybody that their office is has been upgraded, because many of them haven't. And so we have to think about the ventilation and being able, the ventilation to dilute whatever aerosol is being created. If you've got a comfortable mask on, why take the risk? But in the big lecture theaters like Kate and Trevor that you have, I know for sure that they have been upgraded. The HVAC has been upgraded.
I think it's important to know that the public health guidelines have gone through significant evidence-based research, and then through the pragmatic lens of both Bccdc and a number of public health specialists who are on the front line who do this. So I think we do need to model good behavior in public health. I think we actually need to also explain what we're doing and why, and refer to standard guidelines. So certainly I think having a discussion about this with your students and coming to some consensus on how you might like to do it is a good teaching tool, seeing as students are in public health. Certainly that's what I'll be doing with my residents when I meet later this afternoon. And then based on that, I think we can make a plan. But I do think it would be helpful to have something clear in the next week or two, if not from the provost office or from SPPH.
Okay, so I noticed in the chat book, the box, the next few questions, Austin's question, and then Trevor's question, and Tanya Conte has a question, all related to face masks, and I think they're all being answered by somebody. Suhai's question also has been answered. And then I think the next question that is not a face mask question is from Shaheen Menji to everyone. And the question is, what percentage of the population needs to be vaccinated to acquire somewhat resistance to the coronavirus? Shaheen, I can answer you that. It depends on a lot of factors. It depends on whether it's an endemic zone or not, and a bunch of other factors. But the rate of transmissibility is determined by a number of moving parameters. But I'll let David has his hand up. He's definitely more qualified to answer it.
Thanks. Great question. And I'll take a kick at it. But first, I want to give a testimonial for those choir masks. They are great. They've kept me singing throughout the pandemic, and I'm happy about them. So by and large, it is a function of the actual reproductive number. The original virus had a reproductive number of about 3, and the herd immunity threshold then is usually 1 minus 1 over R naught, or about would have been 67%. So you would have needed 75% or more of the population immunized if you take into account that the vaccines aren't fully effective. Delta's been a game changer because the reproductive number for Delta is probably as high as 6, maybe slightly higher. So all of a sudden you need 83% immune, or probably more than 90% immunized. So very much like measles territory to get transmission down. And when we look at transmission dynamic models from various different places, one of the reasons that the vaccine card came in is that we were sort of asymptotically approaching 83, 84% with first dose and presumably going on to second, when we really need to get to that 92, 93%. And so all those models have suggested that if we can get up into that range, maybe another 10% of people in each age stratum immunized, that it will make it very hard for the virus to continue to grow in the population. But that doesn't mean that it can't still get around. As you know, the vaccine may prevent serious illness in almost everybody, but we may still have a little bit of transmission going on. And we must not forget that we have yet to see if there will be a vaccine for children between the ages of 0 and 12.
Okay, and Michael?
Yeah, thanks very much. And yeah, very important, David, about the changing herd immunity thresholds under a more transmissible variants. Another point that I just find important to add in conversations about herd immunity and the thresholds is that while, I mean, these are very important and even very inspiring thresholds as we move forward with our vaccination campaign with such participation from the population, it's important to keep in mind that this is, I like to think of it as a community immunity threshold rather than a provincial herd immunity threshold, and that if there are pockets of less vaccinated people, even if you have 95% coverage across all of long-term care staff, for example, if you have one long-term care home with 80% coverage, there is that opportunity for transmission when you're below that threshold. And that goes for any sorts of people who might associate with one another, whether that's geographical, professional, or social. So very important to keep in mind that on a smaller geographical level or in sub-communities, that threshold applies as well. So we need to think not only of the across the board coverage rate, but from an equity perspective, finding where those rates might be lower and trying to provide opportunities to increase that in those groups as well. In a very practical sense, we've seen this play out at UBC. We had, just speaking, a tale of two waves, having transmission among the student community living in residence and fraternities associated with UBC athletics during the third wave that involved dozens of students very quickly. And this was when school was barely occurring in person. Many people were on campus just as a place of residence because they had work, because they were involved with athletics. And we had a very large case of clusters. We describe it as an outbreak among partially vaccinated and largely unvaccinated young people at that time. And we've certainly also had COVID exposures on campus in the on-campus residence community, either formal UBC housing or in the fraternity or sorority community, that have not gone on to become large outbreaks in the same way. And while their transmission can still occur, even when we're above those herd immunity thresholds, the important point to keep in mind is not that transmission will never occur, but that we don't expect to see that ongoing propagated community transmission. We don't have that transmission matrix, that's somewhere for the infection to go when we have very high rates of coverage that we've seen. So having managed or been involved closely in both of those outbreaks, and the second one, in fact, not becoming an outbreak, very pleased to report on the effectiveness we've seen of high rates of vaccination, even in a group that was, I would report quite candidly, extremely social, having some of the highest direct contact rates you might suppose, but seeing very limited transmission in a situation where many of us had quite a bit of trepidation when we received those first few cases from these UBC events that just did not become larger outbreaks. Of course, we need to monitor those outbreaks, do the same contact tracing and management we've been doing all along, but that's really, I think, the effect of vaccination in action.
Thank you, Michael. That's great. I'm going to move to the next question as we are running out of time. Michaela has received an anonymous question, and the anonymous question is, has there been discussion allowance for hybrid format, in-person classes some weeks, other weeks online, where there is still some in-person interaction, but lowers the number of potential chances for exposure? Let me quickly say that we have always had online courses and we have had face-to-face courses, and criteria are used to decide whether a course is online or face-to-face. And those criteria actually haven't changed with COVID. We have a number of reasons and number of courses that support distance learning and other conditions. I've had a recent discussion about one course which is hybrid, which was pre-approved to be hybrid. And it makes a lot of sense for that course to be hybrid because the number of students in that course is exceeding 50, and they have some small group sessions. So for that course to have breakout groups, you would need 7 or 8 extra classrooms, and just having it online is more efficient for those sessions when you have breakout groups. So those are the kinds of considerations that we've had discussions about. Other than that, I'll go to the education team if you want to add to that answer.
Yes, there certainly was discussion. Earlier in the summer, we responded to Faculty of Medicine request for all classes to submit their plans, and certainly there was a number of different models that were put forward. I think the reason given here to lower interaction, is certainly a reasonable one if it also does not affect the quality of the educational experience. So, for instance, just simply going to a flipped classroom where more work is being done by the student asynchronously, there's less sort of didactic lecturing, you have usually a reduced amount of contact time because you're working in doing activities in class rather than simply lecturing and answering questions. So that was the case for my own class. I flipped it as finally motivated by COVID to finally get around to changing the structure of my own class, and I've reduced my contact time by 20 minutes per session. So a total of 40-minute reduction in contact time. Other people, you can choose to move classes outside if the weather's fine. All of these things just make sense, common sense. And as I said, going forward, I can see more classes adopting hybrid and high flex even kinds of teaching modality. As you see from this session, at least in here, this high flex meeting is working very, very well. We have 3 rooms now in the building, which is Zoom enabled. We also have a
Right. So this is Karen speaking again. Well, I worked with CTLT early in the summer to talk about hybrid. And so their suggestion was a mobile studio for rooms that were not already set up for that. And I'm happy to announce that it was delivered this week. And so we're testing it out now, and Stefan knows how to use it. So between the mobile studio and Stefan, we should be able to create more space that can go hybrid.
Trevor?
Yeah, just to say that we held 2 two-day in-person courses, one in July and one in August, with hybrid, and tested out many of the Zoom setups available to us, and it worked really well. And we use it in particular because we have residents who are learning in different locations around the province, so it allows them to actually participate in the more fully in the actual in-person course on Friday afternoons. So for those who were a little bit anxious about how it might play out, it's quite smooth, and Stefan and Kevin, of course, do a job in the back end, as have our staff to make sure it's a success. So.
And I would just add for staff, for administration too, we're going to be seeing increasing need for hybrid and sort of high flex kinds of meetings. So it's encouraging that we have these facilities. I can only assume that they're going to grow, that each year we're going to have more and more rooms that are converted, allowing for more and more hybrid and high flex teaching and meeting and seminar opportunities.
Thank you, Hugh. I am now going to turn to the next question, and a bit intimidated by smart people, and I don't understand the question, but I think Michael Brower is arguing for the mask mandate, but I'll let Michael explain what he wants me to ask. I'm not sure there's a question, but I think Michael wants to say something. So Mike, it's over to you.
No, thanks, Hassel. I'm not really a question. I was just making a comment just based on the policy that was mentioned, and because I know Trevor had mentioned plexiglass. So I was just saying what the evidence suggests, that plexiglass would be a huge waste of money. It's not effective, and strictly distancing is also not effective. So distancing is helpful, but distancing on its own is not effective. So this is just another suggestion that even though the policy may not be exactly clear on wearing masks, if you want to protect others as much as possible, you should continue to wear a mask when lecturing.
Okay, thank you, Michael. We are coming to the end of our scheduled time, but we actually have booked this Zoom room till 11 till about 12 o'clock. So let me give some concluding remarks, and then I would like to allow this discussion to continue for those of you that don't have to rush off to another meeting. So, Michael gives me a good segue at the department. We have plexiglass barriers, and because the School of Occupational and Environmental Health had ordered them for some other purpose, and during our management committee meeting, we were asked to install them, and it was my decision not to do so because of exactly what Michael said, and second, because it is very important for us at the School of Population and Public Health to be demonstrative of where we are from, who we represent, and to support our public health officer in what they're saying. So if we were to say that plexiglass are not effective, and to then have the School of Population and Public Health have plexiglass barriers in their reception area would be contradictory. So I want to end by saying that we are all at the School of Population and Public Health, and the people are looking at us. So we have to show leadership in this area. We have this extra burden of not only being good citizens, but also to be role models in terms of what other people expect from us. So I know all of you are doing that, and I applaud you for that. And I thank all of you. And this has been a great session. And please continue talking. We have the room booked till, I believe, 12 o'clock. Am I correct, Stefan?
I think so.
I'm going to say yes. For us, it was originally scheduled for 10:30. Yeah, no, 10:30 to noon. And I just want to say there was a question posted about the policy for testing for people working off campus at a hospital. The Faculty of Medicine just sent a document yesterday, a kind of Q&A format that responded to a series of questions like this. If I'm a UBC faculty member but working at a hospital, what's the requirement for testing? So yeah, I can follow up with individuals and share that if you haven't received it, and hopefully that will respond to your questions about, I'm UBC, but I'm not working at UBC, and what's the requirement? So I can share that, so hopefully we'll respond to those questions.
Mika, we've met with that quite a bit at Bccdc, and the university is very clear that where facilities are on health authority territory, that the health authority guidelines are applied, not the UBC guidelines. So just very clear.
Very clear. Yeah, that's the consistent message in all of those questions is that, if you're working on a non-UBC site, then you are under those guidelines for the other site. Yeah.
Yeah. So I'll just chime in and say, being the director of a research center which is based at a hospital site at Providence Healthcare, I have I've tried to be consistent and apply UBC policies, and I've been told that there is slight differences in the two policies. But if you look at the intent of the policies, they're very similar. And so while UBC policies may seem a little bit more restrictive, I think changes coming down the road, at least Vancouver Coastal are going to make those even more restrictive. So I think there's very high levels of concordance. Just from technical HR perspective, we might have to be aware of slight differences in policies. But if you take the high moral road, I think we'll be safe in both environments in terms of our behavior. I'm happy to for other people to chime in. I'm also wondering, we have other colleagues who haven't said anything from maybe Bccdc or from other parts, if they would like to chime in, please do so. I also want to say that because there's so much a need for these kind of town halls and people look to us, I'm considering putting this recording up on our website for other people to see. However, if anybody is opposed to this, just send us an email, and without your consent, if you do not consent to this recording being available to others to view, including our own students, if you have criteria that you don't mind it being shown to our students, but not to other students at UBC, let us know. Otherwise, I don't know if asking for this kind of negative option billing where you have to actually oppose it is okay or not. I'm going to the chat box. Go ahead.
I was just breaking the silence to say that I would absolutely consent to that. That's just fine.
There are some more questions trickling in. Another question from Austin is, in non-student facing areas, what is the policy for face masks in shared office settings? What is the feasibility of fully vaccinated people in shared office settings for making internal agreements regarding mask usage?
So I don't know if Trevor, I'll try, and Trevor's going to pull up the guideline more specifically. I think if you are a worker to worker in your own office, a mask is not required, notwithstanding the feedback that we heard today from Michael and David and others, and that you can also mutually agree to wear a mask in that setting. There is nothing prohibiting you. You personally can wear a mask as the other individual. But if it's a work to work, if Hugh and I are meeting in my office, it is not.
It's public versus non-public.
It's the public versus non-public that is the defining factor, and that's considered a non-public interaction in the office space. Trevor?
Yeah, so I mean, again, everyone can have a personal choice to do what they feel they need to do when it comes to masks in particular. But the Bccdc guideline is the synthesis of both evidence and praxis, so actual implementation of this on the ground. And it is drawn from evidence of transmission in certain contexts. This is what it says. It says masks are not required for workspaces such as office areas, research labs, or shared offices that do not serve the public. So you do not have to wear a mask in those settings. But you may agree as a group, you feel more comfortable if you do.
And some labs are also teaching environments, which is slightly different. So just, that it's a lab is a workplace where it's workers, it's not public facing. And so labs can have dual purposes. So that's just a little caveat.
Thank you. Thank you. We have had some student reps on this call too. If the students would like to add anything to the conversation we have, please feel free to do so. In addition, if anybody does not have a specific question but would just like to comment, feel free to do so. All right. It looks like we've exhausted the questions in the chat, and there are, if I'm reading the room correctly as I'm seeing it, I think this might be an appropriate time to end this meeting.
Thanks, Aslam.
Thank you. Thanks, everyone. Enjoy the weekend.